Hi, I'm Gail Stotler with Vein Access Technologies. And today I want to talk to you about the next generation venipuncture. It's a STEM-based venipuncture method, science, technology, engineering, and math-based. Current methods are not. And this venipuncture problem is common to nursing, radiology, and laboratory medicine. So the solution for one is the solution for all. And I want to tell you about that STEM analysis and that STEM development. I want to tell you how it impacts your institution, how it impacts the performance of this skill, how it impacts the worker performing that skill, and how it impacts the patient. The entire medical outcome, the medical process, can be improved with an improvement in this venipuncture procedure. So let's begin. Let me expand on the complications that come out of venipuncture as they're currently performed. With respect to the IV, when the nurse is infusing Pitocin for the delivery, uterine contractions to deliver the newborn, the baby, if the Pitocin is infiltrating, then it's not reaching the uterus directly. There will be a slow absorption of the Pitocin from the subcutaneous tissue, which takes hours. That prolongs, delays the delivery. That can have complications. With respect to blood draw, that tourniquet alone, there are other contributions, but the tourniquet alone causes hemoconcentration, falsely elevates the glucose level and other lab results. Falsely elevated lab results aren't accurate. Wrong diagnosis, wrong treatment, unacceptable medical outcome. And in X-ray, if the contrast is infiltrating also, just like with IVs, then the contrast isn't reaching the target organ. So is it not visualizing, the organ not visualizing because it's sick or because the contrast isn't reaching the organ? So these are all complications and compromises that come out of current venipuncture methods. This can all be fixed with the VAT method. So let me introduce it this way. There are three foundational pillars in the practice of medicine: nursing, radiology, and laboratory medicine. These are diagnostic foundations and therapeutic foundations. They affect the medical process. So this venipuncture in these blood draw, IVs, and injection of contrast procedures is a very important tool. It must yield an accurate result. A scientifically performed venipuncture can be trusted to yield an accurate result with an accurate diagnosis, followed by an accurate treatment with a predictable medical outcome. But the converse is even more true. A venipuncture performed in violation of the laws of science, technology, engineering, and math ends with inaccurate results, inaccurate diagnosis, inaccurate treatment, and altered medical outcome. So first and foremost, Vein Access Technologies identifies venipuncture as a surgical procedure that should be taught as such and executed as such. This requires teaching and training. VAT took STEM and applied it to this procedure, changing the way in which these procedures are performed. So we're not talking drastic tool changes and expensive tool changes. We're talking about technique changes that can prevent the complications, compromises, injuries, and failures currently associated with current technique. So the VAT method is the next generation. It's just a matter of the industry finally taking a close look at it, acknowledging the science, teaching it, implementing it, and experiencing the benefits of it for all venipuncture. Okay, let's compare old with new. So the current method locates a vein by looking, dilates a vein with a tight tourniquet. They don't grade the vein at all, not a concept considered yet. They access the vein at a 15 to 30 degree angle by gripping and shoving the needle. And their teaching method is self-taught. They are literally just told, pick up the needle and start sticking. And it's usually each other in the classroom and or for nursing when they get on the floor, first time with the patient. The VAT method, on the other hand, has developed a new palpation technique for locating, dilating, and grading veins with gentle touch. And it works 100% of the time. We access the vein at a 45 degree angle, which math dictates. And the teaching method is a detailed one-on-one academic and surgical instruction on the science behind the skill. Stark difference compared to the current methods. With the current methods, and you'll discover this when you read the literature that I've included at the beginning, but with the current methods, there's a stick success and failure rate of 50-50, and that's for all three disciplines. And with it, along with those failures, comes the complications, compromises, and injuries. But with the VAT method, literally, there is a 95% success rate of a first stick event. And we don't have the CCIFs. With the current method, the tourniquet distorts the vein. It forces an over distension of the vein. That even sounds mean. There are side effects to that tourniquet. There's vein rupture upon venipuncture, there's infiltration, there's hemoconcentration, there's bleeding and bruising, there's pain, and of course it causes fear. So all of those things are part of the CCIFs. But when we look at the VAT method, there's a new tool, inexpensive, and it's called the venicuff, and it supports the venous system. It doesn't distort it. And we don't have any of the side effect complications that the tourniquet has. Big improvement. Regarding that needle angle of entry, current standards of care dictate 15 to 30 degrees. And you can see how low that angle is. Okay. Well, that creates friction, grab, and drag. And that requires then that the needle, somebody has to grip and shove to overcome the friction, grab, and drag. There's 5 times more vein wall damage with that low angle entry. Takes longer to seal with the clot and heal with the scar. So there's more bleeding and bruising. And it's more painful because that wall muscle is innervated. But we look at the VAT needle angle of entry at 45. Yes, it's steeper, but there's less friction, grab, and drag. And you can actually feel the frictionless give as you penetrate the vein wall. So you know exactly when to stop. And if you've selected the right size needle for that vein, you're perfectly centered in the canal of that vein. Less vein wall damaged, quicker sealing and healing time, essentially no bleeding and bruising because we're also going to apply pressure appropriately at the end. And there's no pain, literally, because there's a new gentle touch needle insertion technique that avoids that. There's always one nurse in the entire hospital where they go, she's good, go get her. And the patient says, I didn't feel a thing. But they can't tell you what they do differently than all the rest. VAT can, and we can make each person who performs venipuncture that skilled. So when we look at current needle insertion technique, there is none with the current method. They literally just pick up a needle and stick. No one's ever instructed them about how to hold it, the amount of pressure to apply to the needle. It's essentially self-taught, and it results in grip and shove. With VAT needle insertion technique, because we have the grip pressure assessor tool, we can teach them how much pressure to apply to that needle. And we use the pads versus the tips of the fingers. There's no gripping. It's a gentle touch versus a grip. And there's a glide insertion versus the shove. Night and day difference on that needle insertion, all science-based. VAT even corrected for the ergonomics as related to this venipuncture. Current ergonomics, there are none. The tourniquet can be high, the tourniquet can be low. Many things can serve as a tourniquet. Surgical tubing, a true tourniquet, latex, a cinch strap. They look sideways at the insertion needle, or their head is 2.5 feet behind the target. The same hand holds a needle in and wedges a tube on. The patient's arm is straight, the patient's arm is bent. The patient makes a fist, the patient milks the hand. They shove a tube on, they yank a tube off. Some sit, some stand, some squat in the ambulance van. Each person performing the procedure puts their own spin on it. Well, this isn't art class. This is a surgical procedure. We need scientific precision. And the VAT method does just that, and it's guided by physics. So the position of the person performing the venipuncture has to be a particular way. The patient's arm has to be positioned a particular way. And all of this is taught in the VAT program. Site selection is another huge difference. Literally, with the old method, they are taught to look for something blue and stick. And if they can't see something blue, then trust the vein diagram. It doesn't work like that. Not all veins are created equal, number one. So the vein site selection site with VAT is with gentle touch, because not all veins are visible, not all veins are created equal, and not all visible veins should be stuck. So we teach them how to grade the vein for firmness, size, direction, and depth. And that's covered in detail in the program. They say that the current methods are evidence-based versus ours, which is science-based. And this is another misconception in the medical world, in the allied health world. Evidence-based is trial and error, but it was based on scientific principle trial and error. And the current methods are not. We just covered some of that. So right now, their trial and error, anecdotal and empirical, is what I call the stick and hope you hit something and keep sticking until you do method. And they try to reassure the students, oh, don't worry about it, you'll get better over time. No, if you're doing it wrong and you keep doing it wrong, you just reinforce wrong. And in fact, what does the CCI evidence tell us? The CCIF evidence, the complications, compromises, injuries, and failures I just listed, are evidence that the current methods are not working. They're not correct. So the science-based method is built on all of those scientists you see there on the right. And it's STEM-based, so it's predictable, repeatable, and successful. Current methods are either self-taught in those programs, whether it's medical assistant or nursing or x-ray or paramedic. They stick each other trying to figure it out. On the job trained, where they follow somebody around at the hospital, or YouTube. Can't tell you how many students have said, well, I watched on YouTube. That's not the way to learn an invasive surgical procedure. So the VAT method is highly trained, highly educated, and skill demonstrated before they ever leave the facility. As you can see, the scope, magnitude, and gravity of this venipuncture is huge. It involves all the three disciplines and EMS. The magnitude is millions of venipuncture occur every year incorrectly, with lots of complications, compromises, injuries, and failures. And the gravity of it is that it adversely affects the diagnosis, the treatment, and the medical outcome. Your institution, your patient, and your worker is paying for that in some way, shape, or form. And it can change, it can be improved upon. Not to hammer it too hard, but these three venipuncture procedures are the technological foundation of diagnosis and treatment in the practice of medicine. They must be performed correctly. STEM-based methods. And as currently performed, they are costing your institution hundreds of thousands of dollars each year and costing the industry millions of dollars each year. Again, you can do the literature search yourself, or I can provide you with the extensive bibliography on articles related to nursing, laboratory medicine, and radiology, and the other disciplines that use the venipuncture procedure that talk about all of the problems with that procedure. It's just up to this point, none of them have ever offered a solution to the problem. And VAT has that solution. It is the next generation. Vein access technologies can fix this. Please take a look at the websites, either vatmethod.com or STEM21cva.com. Both will give you the science, the technology, the engineering, and math applied to this next generation venipuncture. And then call us, schedule a conference, a consultation with us. See how we can help your institution not only come into the 21st century, but improve the quality of care for the patient and reduce cost for the institution.